Hello and good evening, everyone. A very good evening to all my dear students. Can you please let me know in the chat box if my audio and video is clear? Please let me know in the chat box if my audio and video is clear. Okay, right. So good evening, Pratisha, Tejas, Ahana, Ijas, Nilavudi. So good evening to all of you. Those who are joining live for this session, this is a very concise and crisp discussion of the 10 MCQs that were asked in the Monday midday quiz. So Monday midday quiz is a series of MCQ exams that we are conducting every Monday in the DocTutorials app. So just 10 MCQs to be solved in 5 minutes, and this is based on a particular topic. So this is to make learning a lot easier for you and more focused. Like you can learn one topic and then appear for the exam. So today's topic is HIV. So I can see that good number of students have taken the exam, and I can see rank 1 for the exam is Dr. Indragni Ghosh. I think she's from Kolkata. So congratulations. And I can see others also performing well. Rubina, Lakshmi. So congratulations to all of you. Right. So let's carry on with this discussion. As I said, I'm not going for an elaborate discussion, just 15-20 minutes. That will be the duration of the session. Okay, just a concise discussion. Okay, so let's start the session. So question number 1. In the replication phase or the replication cycle of HIV, the virus cell fusion occurs as a result of formation of hairpin structure mainly mediated by GP120, GP41, CCR5, and CXCR4. So in my lectures on HIV, I have gone into the details on the life cycle of HIV, and I have correlated this with the drugs that can be used in the treatment of HIV as well. So if you remember, in the early part of the replication cycle of HIV, what is the most important step? You know that the GP120 on the viral cell will interact with CD4 on the host cell. So the first interaction happens between GP120 and CD4. As a result of this interaction, that is the first interaction, there is a subsequent second interaction of GP120 with the co-receptors, that is CCR5 and CXCR4. This will be the second interaction. Okay. Now, as a result of the second interaction, what will happen is that there will be a conformational change in GP41. So what is going to happen is that the GP41 will first change its conformation, and on one side, the GP41 will attach to the viral cell membrane. On the other side, it will attach to the host cell membrane. And then what would happen is that it will bend on itself, just like a hairpin. It will bend on itself so that it will cause fusion of the viral and host cell membrane. So all these interactions are important, but what is that forms the hairpin structure, or what is that results in the formation of hairpin structure? It is quite evident. It is the GP41. Okay, GP41, and that is what is the answer. The answer is option B, GP41. Please go through the entire life cycle of HIV that I've explained in my lecture in the DocTutorials app. I've explained in a very simplified manner. So please go through the lecture. So this one I hope is very clear to you. Please give me a thumbs up if you are confident on this? Just give me a thumbs up in the chat box. Moving on to question number 2. For HIV testing and diagnosis in clinically symptomatic individuals, retesting after 14 to 28 days is recommended by the NACO, that is National AIDS Control Organization, in which condition? So remember, for HIV testing and diagnosis, for the screening test, as a screening test, you will go for a 4th generation serological test. So what is this 4th generation serological test? It is a combined antibody antigen test. So combined antibody and P24 antigen, that is the test used for screening. So once the screening test is positive, you will go for a confirmatory test. So how do you confirm the diagnosis of HIV? Remember, in my lectures, I have classified based on 2 algorithms. So the algorithms are based on whether the patient is clinically symptomatic or clinically asymptomatic. So this question is regarding patients who are clinically symptomatic. So let me quickly take you to that algorithm, clinically symptomatic patients. So you've got 3 tests, A1, A2, and A3. So basically, what are these 3 tests? A1, A2, and A3 are tests which are very specific, and these tests are based on different principles or antigens. So when I say different principles, say for example, one assay, A for assay, okay? One assay, say A1 may be based on immunoassay, A2 may be based on immunochromatography, and A3 may be based on another principle. So you can have these tests which are varying either in the principles or based on the antigen. Now you can use different such assays. So you have got to use 3 assays here. And as you can see here, if A1 and A2 are positive, definitely the test is reported to be positive. If the first test A1, which is a very sensitive test, is negative, then you can already say that the patient is HIV negative. A1 positive, A2 negative, and A3 positive, this is what is indeterminate. And A1 positive, A2 negative, and A3 negative is a report is negative. So here you can see that this patient who is having indeterminate is being asked, correct? So A1 negative. So what do you think is the answer for this question? What do you think is the answer? A1 positive, A2 negative, and A3 positive. I think we have, I think, it is, did I type it wrongly in the options? So it should have been A1 positive, A2 negative, and A3 positive. So that is indeterminate, and it is in indeterminate cases that you will go for a repeat testing or a retesting. Okay, right. So A1, this is actually negative. Okay, so A1 positive and A1, this is negative. This is negative. A1 positive and A2 positive. This is positive. A1 positive, A2 positive, and A3 negative. I think, it's A1 positive, A2 negative, and A3 negative. This is also negative. Okay. Right. So A1 positive, A2. So I think it's just, it's a typing error. It should be actually A1 positive, A2 negative, and A3 positive. Okay. I hope that is clear. Right. So that is clinically symptomatic individuals. Okay. Right. So I hope you understood there is a typing error there. Okay. So I'm not going into the algorithm for clinically asymptomatic patients, which I've already explained in my lectures. Coming to question number 3. Question number 3. How does the risk of infection for a healthcare worker after a needle stick injury compare from greatest to least risk for hepatitis B, hepatitis C, and HIV? So the question is regarding the risk following a needle stick injury. So for hepatitis B virus, what will be the risk? The risk will be 30%. Hepatitis C virus, the risk will be 3%. And HIV, it will be 0.3%. So what is going to be the answer? The highest is for hepatitis B, followed by hepatitis C, and then least for HIV virus. The answer is option D. Please let me know if you are clear with the answer in the comment section. Give me a thumbs up. Okay, give me a thumbs up. right? The answer is option D, right? Coming to question number 4. What is the most commonly encountered neurological complication of HIV? Is it cryptococcal meningitis, distal symmetric polyneuropathy, HIV-associated dementia, and progressive multifocal leukoencephalopathy? So what is going to be the most commonly encountered neurological complications? So you've got to understand the HIV-related neurological complications can be categorized to two. Either it can be due to the direct effect of the virus, which is HIV-related, or it can be opportunistic infection related. The direct effect of the virus could result in an aseptic meningitis or a chronic meningitis, HIV-associated neurocognitive disorder, HIV dementia, vacuolar myopathy, which is a spinal cord affection, peripheral neuropathy, and myopathy. The neurological manifestations due to opportunistic infections include cryptococcal meningitis, cerebral toxoplasmosis, CMV retinitis, progressive multifocal leukoencephalopathy, primary CNS lymphoma, tuberculosis, and syphilis. So here they have asked about most commonly encountered neurological complication. So what is going to be the most commonly encountered neurological complication? This is a peripheral nervous system affection, and you will have a distal symmetric polyneuropathy. So a peripheral nerve involvement is much more common than central nervous system involvement. So the most commonly encountered neurological complication now is a distal symmetric polyneuropathy, that is the peripheral nerve involvement. Okay, right. So that is pretty clear. Okay, right. Now, coming to question number 5, 56-year-old patient with AIDS develops slowly progressive spastic paraparesis, sensory impairment, and bladder dysfunction. On his examination, he had hypertonia and deep tendon reflexes were brisk. After death, the examination of spinal cord at autopsy is most likely to demonstrate which of the following findings: extensive microhemorrhages, gray matter liquefactive necrosis, patchy demyelination, and white matter vacuolization. So this question is also regarding a neurological manifestation of HIV. So what is this neurological manifestation? You can see that patient is having progressive spastic paraparesis. There is some sort of a sensory impairment and also bladder involvement. And hypertonia and deep tendon reflexes were brisk. So definitely this is a UMN paraparesis, because you have got all the UMN features like spasticity, hypertonia, and brisk deep tendon reflexes. So the spinal cord affection is likely to show what pathological change is being asked. Now remember, in case of the spinal cord affection in case of HIV, they've got an affection by name vacuolar myopathy. So the spinal cord affection is known as vacuolar myopathy. Can you have any other type of spinal cord affection in HIV patients? Yes, you can have HTLV myopathy. It is also possible, but by the HTLV1 virus, correct? So you can have HTLV myopathy, but this one is a direct effect of the HIV virus, and this can cause the most common spinal cord disease in AIDS. So why do I say this is the most common? Because other viruses like HTLV, cytomegalovirus, Epstein-Barr virus can also cause myelopathies in HIV patients. Now, when there is a vacuolar myelopathy, the pathology that you would expect is a vacuolization of the myelin sheath, which would result in accumulation which would result in a damage to the myelin sheath, and pathologically there would be an accumulation of foamy macrophages and microglia. And since the damage is mainly to the myelin sheath, the axons are relatively spared. So vacuolar myelopathy is an important pathological change that you should know about spinal cord affection in case of HIV. My dear students, are you clear regarding this? Are you clear regarding this? Yes, let me go to the next question. Give me a thumbs up if you are clear regarding this. Right. Question number 6. An HIV patient on ART presents with features of bleeding diathesis and also with headache, vomiting, and altered sensorium. What drug is likely responsible? Well, for bleeding diathesis and some features of headache, vomiting, and altered sensorium. Let me tell you that this is a very tough question. And still, why did I ask you this tough question? Because those who have already done your previous year question would have seen the exact same question in INI November 2023 examination. Exact question. This is a recall-based question. I just wanted to see how many of you have gone through the recall videos of INI. So my recall video of INI November 2023 is also available in YouTube. Now, these are all, the options are all protease inhibitors. But what is being asked? Which protease inhibitor can result in bleeding diathesis? And as a part of bleeding diathesis, when a patient develops headache, vomiting, and altered sensorium, please think of an intracerebral hemorrhage. Please think of an intracerebral hemorrhage. Please think of an intracerebral hemorrhage. Okay. So, what do you think? Which retroviral agent is likely to produce this? The answer is option D, tipirnavir. The answer is option D, tipirnavir. Okay. So, it is very important. The table that I'm just showing you is the list of antiretroviral drugs, and the ones which are highlighted in dark are the drugs which are available in our national program. Tipirnavir is not featuring in the national program, but still you've got a question in INI based on tipirnavir. So this is why I want you to know regarding this drug. Okay, right. Question number 7, 40-year-old truck driver presents to the physician with watery diarrhea of 3 weeks duration. Stool evaluation showed oocyst that would stain with acid fast dye. Choose the false statement regarding management of the patient. So what do you think? Dr. Pratyusha, Aladi Vinay, Chippy, what do you think? What is the diagnosis here? So truck driver, okay, again, high-risk individuals for developing sexually transmitted diseases. Then patient is having diarrhea of 3 weeks duration and oocyst that stain with acid fast dye. So what do you think? The patient is likely to have a retroviral infection, and this could be a Cryptosporidium parvum infection. Okay, this could be a Cryptosporidium infection, right? So the diarrhea could be due to Cryptosporidium. Okay, so they're asking regarding the false statement regarding the management. The first statement is aggressive rehydration and replacement of electrolyte loss. Now, this is true. It's a true statement. So there is nothing wrong regarding this. You have got to choose the false statement. Delay ART for 2 weeks to prevent iris. This is absolutely a false statement, and this will be the answer here. Because remember, in case of a Cryptosporidial infection, this happens because the immunity is significantly suppressed. So iris in this case is very unlikely. So here what you have got to do is specifically the NACO guidelines, when they give out the treatment suggestions about Cryptosporidium infection, one major point they highlight is rapid initiation of ART. There is no point delaying ART. Please go for ART rapidly, rapid initiation of ART. Then nitazoxanide 500 milligram orally twice daily for 14 days. Paromomycin 500 milligram orally 4 times a day for 14 days. So these two, you can either go for nitazoxanide or you can go for paromomycin. They are correct statements. So the question is regarding the false statement, and that is going to be the option B. Okay, right. So let's go to question number 8. 45-year-old man with HIV presents with lumbar paraspinal pain and numbness affecting his legs. So symptoms are there in the paraspinal region in his lower limbs, and he is having bilateral lower extremity weakness. Knee jerk is diminished bilaterally and ankle jerk was absent bilaterally. So you've got an involvement with some sensory symptoms and also motor symptoms. So knee jerk diminished and ankle jerk absent bilaterally. What does it suggest? LMN or UMN? It is LMN. Definitely it is going to be an LMN weakness. Let me just stop here. I think I can see two doubts there. Iris happens only with tuberculosis. No. See, tuberculosis, not only tuberculosis, CME infection, they are all associated with reactivation. You can have iris associated with cytomegalovirus infection, TB. You can have iris, but Cryptosporidium causing iris, it is not a possibility. Okay, if you go through my lecture in the DocTutorials app, I have specifically said to which all infections you should delay antiretroviral therapy. Cytomegalovirus, PCP, tuberculosis, you should delay. But have I ever mentioned regarding Cryptosporidium? No, it is a GI infection. It is a GI infection. You have to just go for ART aggressively, which will definitely result in improvement of the symptoms. Almin and Aladivinay, I hope I am clear there. Right, let's come back to this question. So we are quite sure that we are dealing with a lower motor neuron type of clinical presentation, and the nerve conduction study and EMG suggest a lumbosacral radiculopathy, and MRI is showing an enhancement of the cauda equina. Lumbar puncture revealed elevated protein and polymorphonuclear pleocytosis. Which of the following infectious agents is most likely responsible for this patient's radiculopathy? Okay, so options are HSV1, HIV, cytomegalovirus, and varicella zoster. Now, when it comes to peripheral nervous system involvement in case of HIV, when it comes to the nerve involvement, let me tell you, the common patterns of nerve involvement include, number one, a distal symmetric polyneuropathy, that is number one. Okay, that is the most common as well. Then mononeuritis multiplex, chronic inflammatory demyelinating polyneuropathy, and then it is progressive lumbosacral polyradiculopathy. So these are the possible affections of the peripheral nerve. Now, they're asking what is the likely agent. Now, you've got to understand here, the patient is having a lumbosacral radiculopathy, which is why he is having some pain over the paraspinal region, and he is also having some symptoms in his lower limbs. Okay, now remember, in HIV patients, when you get a lumbosacral radiculopathy, do you know that the lumbosacral radiculopathy is not happening because of a direct effect of the HIV? Because you might have seen one of the options was HIV. At least some of you thought, already sir has given HIV in the question. So what is the likely infectious agent? It could be HIV. No. Do not think, I was that silly to give an option of HIV. So on purpose, I put the option of HIV, because you should know that the lumbosacral radiculopathy that commonly happens in HIV patients is not directly because of the effect of HIV. It is because of the effect of cytomegalovirus, that is CMV. So what is going to be the answer here? It is going to be option C, that is cytomegalovirus. Remember this one-liner factual question. The most common cause of a lumbosacral radiculopathy in an HIV patient is cytomegalovirus. Okay, are you clear on that? Yes. Answer is option C, right? Question number 9, choose the false statement regarding iris. So iris is very important topic. Immune reconstitution inflammatory syndrome. So the first statement says incidence is 10 to 30% in patients initiated on ART, correct? Usually seen in first 4 to 8 weeks of starting ART, correct? Okay, it's usually seen in that window period. CD4 count less than 100 is a risk factor. Yes, when the CD4 count is very less, then the chance of developing iris is more. So you should know what is an iris. That is, once you start antiretroviral therapy, especially in patients whose initial CD4 count is pretty less, you will have an improvement of the immune system, And this would result in some inflammatory reactions that will occur at the site or sites of pre-existing infection, which happens in around 10 to 30% and usually happens in the first 4 to 8 weeks. But what is option D? Option D says antiretroviral therapy should be stopped immediately in all cases. What do you think? Is it correct or wrong? Well, this is a wrong statement, and which is why they have asked about false statement. So D will be the answer. Because I've taught you in my lectures as well, as far as management of iris goes, you can go for short-term therapy with steroids or NSAIDs just to reduce the inflammation. And what about stopping ART? If iris develops, should you stop ART or not? Well, in general cases, we do not stop ART. In certain exceptional conditions, you may think of temporary cessation of ART only if potentially life-threatening forms of iris develops. Okay. And also as a part of the treatment, you will have to recognize and manage the ongoing infection. So if you look at this option here of option D, ART should be immediately stopped in all cases is false. Only in certain exceptional scenarios will you stop antiretroviral therapy. Okay. Now the final question of the Monday midday, that is eccentric target sign is seen in neurocystic sarcosis, cerebral toxoplasmosis, progressive multifocal leukoencephalopathy, and cryptococosis. Again, a simple, straightforward question. This is again asked as a factual question as well as an image-based question as a part of radiology as well. So this is what you are seeing as the eccentric target sign. Can you see a ring? And can you see a nodule also there? Okay, you can see a ring with a nodule, with the particular pattern of contrast enhancement. So eccentric target sign means you have got a ring-shaped zone of peripheral enhancement with a small eccentric mural nodule. This is what is called the eccentric target sign. And this enhancing nodule is a collection of thickened vessels. Okay, so what you are seeing as the nodule here, please have a look at this. The nodule which I am pointing to is referring to a collection of concentrically thickened vessels, whereas the rim enhancement is caused by an inflamed vascular zone that borders the necrotic abscess cavity in the center. So this is actually a feature of cerebral toxoplasmosis. And another point, my dear children, you have got to know about cerebral toxoplasmosis is the predilection to involve the basal ganglia. Is a predilection to involve the basal ganglia as well. So that is regarding option B. That is cerebral toxoplasmosis is the answer. Okay. So I hope you are clear with the the questions that have been asked. I think for one other question, there was a typing error. I'm not sure whether the same typing error figured in the actual exam as well. But, I have already explained the table for you. It is when the test becomes indeterminate, you will have to repeat it after 14 to 28 days. Okay, indeterminate cases. And I also want you to go through the clinically asymptomatic patients algorithm as well, which I've explained in my lectures as well. Okay, so I hope that is pretty clear to you. Okay, so any doubts regarding the questions that I've discussed so far, please let me know. Is there any doubt for the questions that I've discussed so far? I'm glad that all of you are attending the Monday midday quiz seriously, and please watch out for more such exams, okay, in the Monday midday series. Okay, right. All right. So that's it. Thank you everyone for joining. And please do stay connected with the social media handles of DocTutorials for the remaining sessions and the upcoming sessions of the Monday midday. Thank you so much everyone for joining.